Okay, a pleasant afternoon to everyone. I hope everyone's doing great. It's been a busy week for everyone, but we're happy that you are here with us in our webinar series for this October. We care for your mental health. So we know that you are excited because we have two parts for our series, and we have the plenary session, and we also have the workshop series. So this afternoon, we are also happy to have with us our guest speaker, Dr. Janice Taleon, who I will be introducing later. And I also would like to remind everyone to please keep your microphones muted to avoid any disturbances, especially to our speaker as while she is speaking, and of course to our overall program. And after our speaker will speak, we will have a Q&A portion for everyone to ask if you have any clarifications and any questions regarding her topic. So after my part, we will open with a prayer to be held by one of our medical missionaries from Palawan Mission, Ma'am Diane Guevara. And after her part will be a special number coming from Ma'am Queenie Matias. And after the special number, I will be introducing our dear speaker, and we will have Dr. Lalaine for the announcements. And after that will be the workshop series. So I know that everyone's excited to start our program this afternoon. So now may I call on um, Ma'am Diane Guevara, and I also would like to welcome all our health directors, everyone here in the Zoom platform. Hello, everyone. And I would like to also tell you that we are streaming live via Facebook through Dr. Lalaine Alfanosa's Facebook account and through our official Facebook page, Adventist Health Ministries SSD. So please do share this with your friends. And if you would like to watch again this afternoon's series, you can go back to our page and you can watch it again. So thank you, everyone, and have a pleasant afternoon.
Let us pray. Our loving Heavenly Father, the author of life and health, we humbly come before you this afternoon, and we would like to thank you, dear Lord, for this privilege to once again listen from our resource speaker, the lecturer that will help us to understand more about mental health. Dear Lord, we know that you desire all of us to be healthy, not just physically, but holistically, including our mental health. So please be with us this afternoon, especially for our speaker, and may we all be blessed as we listen to your words. In Jesus' name we pray, amen.
I have fixed my mind on another time, on another time.
Thank you very much, Ma'am Queenie Matias, for that wonderful message in song. So our speaker this afternoon is Ma'am Janice. She is currently residing in Iloilo City, Philippines. And she took her secondary and elementary education in West Visayas State University in secondary and elementary lab school. She also took her bachelor's degree in Mountain View College in Valencia City, Bukidnon. She took her medical education in Southwestern University College of Medicine in Cebu City, and she took her postgraduate internship in Manila Adventist Medical Center in Pasay City, Manila. She took her training and specialization in Western Visayas Medical Center in Iloilo City. She has a teaching experience as resource speaker in academic, community, and interagency lectures, as well as psychiatry didactics. Presently, with undergraduate teaching load on psychiatric foundations, she has many trainings, seminars, and workshops, and researches such as the impact of COVID-19 pandemic on frontliners. And her other interests are she's a member of the Helping Hands Ministry, a leadership and philanthropy-oriented group of students and young professionals. She is also a violinist in Soul Strings, a wind and strings quintet, and she is also a member of the Health Ministry Department and Music Department of the La Paz Seventh-day Adventist Church, La Paz, Iloilo City. And her clinical experiences also is she took her clinical experience in Taleon Medical Clinic and Diagnostic Laboratory, Iloilo City. So we are very much pleased to have you with us, Dr. Janice Taleon. I know that you have a very informative message for us this afternoon. And Dr. Janice Taleon's topic will be on understanding mental health and how we can help as a church. So now, Ma'am Janice, I would now give you the time.
Thank you so much, Miss Keisha, for the introduction. I would like to greet everyone a warm good afternoon. I'm assuming that it's PM in neighboring countries of the Philippines. Um, so yes, I'm going to start um, sharing my screen now. Our time is in my clock. It's 2:20. I hope that we will be able to finish uh, uh, a significant number of slides because the assigned task to me is to um, give an understanding, and in the process of understanding is actually to give a classification of the mental illnesses, the major mental illnesses, and after that how we can help as a church. So I I would like to introduce myself a little bit. I could say that my interest, and now my fascination with human behaviors started actually when I was in high school. Although I didn't realize it at that time, I only realized it when I was training. That I remember when I was in high school, I picked up when I was in a clinic a very small a booklet that said body language, and I can remember that it was mostly pictures showing how what it might mean if you are talking to someone and you're crossing your arms, or when you are leaning towards someone while conversing, or tapping your fingers and looking at the watch while listening to someone. I do hope that for my for my well-being and self-esteem, I won't see um, anyone um, in the screen tapping his or her fingers. No? I will try not to keep this as boring as it can be, as some people might find mental health to be. So anyway, it was in college that I had a little bit of an idea of what occupation I might be into, and it was because I had to deal with people, some of them close to me, who had some form of a mental condition. And so it became more evident to me when I rotated in a in a mental hospital as a postgraduate medical intern. So as for the following lecture, I claim no authorship in anything except for possible accounts of personal experience with patients, and the contents are basically based in on psychiatric textbooks, the diagnostic and statistical manual, as well as material from other professionals involved in mental health, and as well as the church. And what I'm going to do is we will discuss major mental disorders only briefly, since each of them can be separate lectures on their own. No, and there will be a bit more discussion, and probably um, or we can discuss more later during the so I hope that is clear. So it is said that um, there is no health without mental health. So what would it mean to be healthy in the first place, to be mentally healthy? The World Health Organization, as I'm sure, quite possibly the lecturers ahead of me might have defined already, would say that it is not just the absence of a mental disorder. Just like it's quite similar to how you would um, define health in general. No, it's not just the absence of disease, but mental health, according to the World Health Organization, is that uh, is a state of well-being in which an individual realizes his or her own capabilities and can cope with normal stresses of life, and can work productively and fruitfully, and is able to make a contribution to his or her community. So it doesn't just mean um, a it wouldn't just mean behavioral changes, because sometimes you won't even notice changes in behavior of people, but you will notice that their work performances are being affected, their relationships are being affected. So that's how you might one might define mental health. No? So partly I might be citing examples in the context of being in the Philippines. You know, so just recently, the people in the mental health world were excited here in the Philippines because just I think 2 years ago that the mental health law was finally passed, and it is because of this law that um, patients with mental illness can expect better service. They can expect that more of the government's budget can be allotted to rendering services to our brothers and sisters who have a mental illness. So under that particular law, they have grouped um, three main subcategories of mental health, which is psychiatric, the neurologic, and substance disorders. So that if those of you who don't live in the Philippines, you will find later on that um, in terms of budget allotment, in terms of classification and the use of our PhilHealth system, you know, um, it could be um, classified. These three categories are classified together. Now, so as for classification of the different mental disorders, the official um, manuals being used are these two, the DSM-5 for the Diagnostic and Statistical Manual for Mental Disorders, and ICD-10. Now, the World Health Organization uses the ICD-10, and it's also ICD-10 that we use when we classify diseases in terms of insurance and writing official diagnosis in hospital documents. But for the purpose of this lecture, I will be using the DSM-5. So you'll be seeing a lot, the DSM-5 uh, word or phrase, and because partly it's because of the training that I've had. We are pretty much used to using DSM-5 because that's usually what's in our textbooks, and it's a bit more practical. So they say that um, one must treat the patient and not just the disease. So it's basically looking at the person as a whole versus looking at and treating person's symptoms. Um, Clinicians, whether it's in psychiatry or not, or in different fields of medicine, sometimes we tend to make I wouldn't say a mistake. No, it's not a mistake either. No, but we tend to treat a person based on symptoms, which is a practical thing, of course. But there are times when doctors and health workers forget to be more patient and more humane and less holistic because of the drive to just treat, for example, a cough rather than looking at what else could be the problem with the entire person. So these are the elements of a psychiatric interview. As you can see, an initial psychiatric interview takes quite some time. Um, Ideally, if you base it on a book, the maximum would be 90 minutes. But if you're in a training hospital, like where I came from, where um, where before going to a doctor, the patients also, because of the training part, know that they have to go through other people and tell and retell their problems, until such time that they get to being a doctor. So they go through the interns first, or sometimes the postgraduate intern. But I would like to show in this slide that that it is not enough to just diagnose a person with mental illness based on what he or she tells you. Like, for example, when a patient comes to you and has difficulty of sleeping, or if a patient comes to you and claims that he or she hears voices. So you can't just say that the person is right away a schizophrenic. Um, a lot of information gathering comes first before anyone can actually diagnose a psychiatric patient. No? Although, of course, um, at the back of your mind, based simply on the, like for example, just the third item here, the chief complaint, based on the chief complaint or what or the reason why the patient came in for consultation, no? You have already an idea at the back of your mind. No? So I highlighted their family history and developmental and social history because these are just as important as conducting a mental status exam, no, and or making an accurate history of present illness. So we tend to, um, you will find when if you get the chance to interview a psychiatric patient that um, a big chunk, of the patient's history and especially the patient's childhood, influences how the patient is at present. So that is very important. Like for example, in a developmental history, we would like to know if the developmental milestones were delayed or not. You know? Like for example, how old did the patient start to walk and talk? you know, um, was he or she able to go to school? How did he or she fare when he was in school? What happened with the rest of the family? Who was the main care giver when the patient was just a toddler or when the patient was just a newborn? Now, these things are actually very important in in being able to understand why a patient behave the way he or she does. So these are the major psychiatric disorders that I will be showing to you this afternoon. So there are mood disorders. Under mood disorders, um, would be depression and bipolar disorder, the anxiety disorders, which would include panic disorder, substance use and other addictive disorders, neurocognitive, meaning the ones that involve brain function, like dementia, and the schizophrenia spectrum. In other words, the spectrum of disorders that uh, present with psychosis, and also the developmental disorders, like intellectual disorder, autism, and but I will only be discussing the main, uh, the ones that are actually here, because I don't think we would be able to finish, if we discuss each of them. They actually, that would mean discussing an entire textbook. So these are the other psychiatric disorders. Just because I am not going to be discussing them, it doesn't mean that they are less important. Just for the sake um, of uh, being able to classify and identify a psychiatric disorders, because some of these may not be so common. Okay, so we shall be starting with the mood disorders. And under mood disorders, as I have mentioned, is major depression. So, and the bipolar disorders. Other disorders in here would mean the less common mood disorders like cyclothymia and dysthymia. I am sure that, I'm not sure how many of you have heard some of these um, conditions before, but you will be introduced to some terms that and psychiatric conditions that you may not have met before. So when you say mood, what we would mean is a feeling or emotion that is pervasive and sustained. So that is the key word when you say mood. In other words, just because someone tells you, for example, that I feel sad because um, my boyfriend or my girlfriend didn't text me or call me today. No, so that is not necessarily a mood, because a mood has to be sustained and pervasive, and and there is a criteria, to that includes other symptoms, for it to be a disorder. You know. Um, so basically, these disorders are virtually always result in impaired personal, social, and occupational functioning, and you will find this to be true with other psychiatric disorders. They became disorders because of how it has affected the way a person functions, negatively. You know. So there is what we would call normal mood. For when, for example, a person is grieving because someone died, and naturally for quite some time you will be feeling sad. It will become a mood disorder when it starts to affect, again, your interpersonal, social, and occupational functioning. So meaning your performance, your work, and your relationships. So the other disorders that are under mood disorders, other than depression and bipolar disorder, are hypomania, cyclothymia, and dysthymia. These are lesser forms of depression and mania. Okay. So this, I instead of writing a simple list of symptoms, I put here the actual criteria that psychiatrists use when they are diagnosing a certain medical illness, you know, so that you will be able to see that one actually has to be as objective as possible when diagnosing a psychiatric illness, because um, of the implication that it will give to a person once you diagnose the person. So you can't just say, just because someone says he or she is depressed, which people tend to use a lot, no, in a regular conversation. No, it doesn't mean that that person is clinically depressed. You would have to, for example, in major depressive disorder, you would have to be able to check, from this checklist, at least 5 symptoms, and these symptoms should last at least 2 weeks. So in other words, because if this is depression and the mood is depressed mood or sad, the person should feel sad or depressed more days than not. No? So more often than not in those uh, in that same 2 week period. And for some people it might not necessarily be a sad mood. It can be a feeling of helplessness, hopelessness, worthlessness. No? and um, according to this, no, at least 5 of these, you should be able to check, but one of them should either be depressed or a diminished interest. Now we call that anhedonia, or loss of pleasure. So in here you will find that when it comes to other symptoms like sleep, um, movement, and weight, it could go either way. For example, a weight change could be an increase or a decrease. Could be because of an increase or decrease in appetite, because um, some depressed people will not feel like eating. Some depressed people manage their depression by eating a lot. No? And it's also the same for sleep disturbance. No? So they say that when you don't sleep, you could be depressed, but if you sleep um, a lot, you could be also depressed. No? So again, these are disturbances. In other words, if a person is used to sleeping a lot or used to sleeping less because of work, no, it doesn't mean that they are depressed. No, so these are changes, that or changes in behavior that is not usual to the person. Also, what else? There's also fatigue, loss of energy, feelings of worthlessness. As I have mentioned, diminished ability to think or concentrate. People become indecisive where they normally are. You know, and recurrent thoughts of death and recurrent thoughts uh, of suicide. So when it comes to suicide, by the way, and or thoughts of death, no one should be able to note and classify this also. No? So there should be another a different lecture for only for suicide. No, was the suicide intentional? Was it done out of impulse? Was there a plan? Um, was there an actual plan and an attempt? No, a plan would include the where and the how, and where there, for example, in a suicide scale, you would find questions like, was there a suicide note? Did the patient prepare for the suicidal act? Because people who are suicide, who have intent to kill self, um, tend to prepare, especially in terms of their family members. People who plan their suicide well would tend to arrange um, important matters like their last will and testament, their properties, so that their family members will not have a big burden, when they die. So they fix their affairs. And there is also a type of suicide that is called a non-suicidal uh, um, NSSI, a non-suicide self-injury. So these are the ones that you would commonly find among teenagers, and also persons with personality disorders, where they threaten to kill themselves by cutting themselves. You can also see this in patients who have suffered abuse. Okay, so um, a mnemonic that students use, for all the criteria of major depression is SIG ECAPS, which would mean sleep, interest, so that's diminished interest, no feelings of guilt, worthlessness, hopelessness, loss of energy, diminished concentration, so appetite could be increased or decreased. So movement, no, there is what we call an agitated depression, where a person, usually this happens in old people, no, they are depressed, but they, instead of looking lethargic, they seemed restless. And as for suicidal thoughts, okay, so bipolar disorder, you know, as the name says, bi means two, pole means an end, so there are two ends, meaning there are two sides um, in a person's mood. I'm sorry, I need to move the because I can't see. Okay, here. Um, so when you say a bipolar one disorder, it means that the person may or may not have had a previous depression, no, or uh, a major depressive episode, but there is a manic episode. Um, and in here, it is characterized by a period of abnormally and persistently. So these are the keywords: elevated, expansive, irritable mood, which lasts at least 1 week. No, but again, because it is mood, it should be present most of the day. No? So a person who is either irritable or expansive and feels like he or she can do anything, that anything is possible. So that's different from being positive, actually. Now you will learn from in the following slide that um, that it's like being overboard with the positivity. So during this period, one should observe these symptoms, no, three or more of these symptoms. But if a person's mood is not elevated or expansive and just irritable, no, one should be able to check at least four of the following symptoms. No, so this is what you would describe a person that they would say as hyper. No, here in the Philippines they would call that hyper. No, so the person's self-esteem is well inflated, and the person seems to be very grandiose. No, a decreased need for sleep is different from a difficulty sleeping, in the sense that or a sleep problem where people actually want to go to sleep. No, so in in people who have sleep problems, usually because they are unable to initiate or maintain sleep, they feel tired and want to catch up with the sleep the next day. But people who are manic, you know, they don't they can sleep for only, as it says here, for only 3 hours, 4 hours, and yet and the next day they are still very active, very energetic, very grandiose. No, and sometimes their folks or their family members would complain that they would clean the house in the middle of the night and keep arranging things and talk, because they don't feel the need to sleep. So that would go to the next symptom, which is they become more talkative than usual. So again, it doesn't mean that a talkative person is manic. So in here, it is a change, in the way a person normally talks. Usually, in mania, um, a talkative person is very difficult to interrupt. No? If you know a person, because it seems this kind of symptom is actually common. No, if you know a person who talks a lot and you claim that that person is difficult to interrupt, no, it may not necessarily be a bipolar one disorder, but it might be a bipolar two or a hypomanic um, episode. But also it may be just that the person is just talkative, which is why you have a criteria so that you can see, if there are other symptoms that you can check. So easily distracted people who are manic cannot focus in one task, and so sometimes they start one task and then another task comes to mind and then they go to that other task, and then they tend to jump from one activity to another without completely finishing any of them. So that is also an increased goal directed activity. They tend to want to do so many things, and sometimes they would tell you that it's not their choice when actually it is. No, they would complain that I feel like I'm the only one who's doing all the work at home, when actually nobody is forcing them to do that. Sometimes it's useful to have a manic patient in the ward because um, the janitor has less work. You know, the manic patients tend to do their work for them. They like to clean up, you know, and work. But but this would also mean other activities like an increase in sexual activity. Manic persons tend to be hypersexual. So they also tend to do, um, they tend to be just restless and agitated. And the last symptom here says excessive involvement in the activities that have a high potential for painful consequences. So like a buying spree, or they engage in gambling and just, you know, make a very consequential and detrimental decisions at the snap of a finger. You know, they make investments they did not think about. Okay. So anyway, if you have questions, just reserve them for later. Now we go to anxiety disorders. Um, Under anxiety disorders are other uh, less common disorders like actually social anxiety is pretty common. Phobias, you know, agoraphobia, or the fear of being in open spaces. You know, and so there's panic, and there's generalized anxiety disorder. So anxiety disorders are associated with uh, significant morbidity and are often chronic and resistant to treatment. You know. So as with a mood disorder, you know, an anxiety disorder tends to affect a person's functioning. Because of the anxiety, their work can be affected. You know, so, but there is also normal anxiety. You know, just like stress. Stress is actually, if not excessive, actually helps us to accomplish things. So anxiety, if it is normal, it helps us also to um, to be watchful. So what is normal anxiety? It is a diffuse, unpleasant, vague sense of apprehension. You know, often accompanied by autonomic symptoms. When you say autonomic symptoms, these are symptoms that you don't control. No, it's your brain controlling it. No, so there's headache, palpitations, perspiration, tightness in the chest, mild stomach discomfort, and restlessness. And I the usual thing that I would find myself telling me, at least here in Iloilo, is that they feel like there's air that's coming from the stomach and that it's moving upward to the head. So I don't know. It Anxiety is actually pretty common. One of the things that I didn't realize now until I started training in psychiatry, because anybody can have anxiety because it's normal. You know, but disorders, you know, I find it that they are actually pretty common. You know, and you wouldn't know that because unlike mood disorders or psychosis, people with anxiety, even anxiety disorders, can also be functional. Like they are high functioning professionals. You know? but because of the job, of the pressures of the job, no, they tend to experience anxiety disorders. You know, having increased workload, deadlines, you know, and um, and the demands from their from of the job. So, what is fear as opposed to anxiety? Anxiety, it says here, is an alerting signal. In other words, it warns you of something that is going to come, you know, that might be dangerous. So, in other words, the person who is anxious is going to prepare. Now, fear is also alerting, but it is a response to a known external or definite threat. So, the key word to distinguish fear from anxiety is what is known and what is unknown. So, for example, um, if you hear from the radio or if you watch from the weather forecast on TV that there is going to be a typhoon signal, that what you're feeling is fear, especially when you are, for example, traveling at sea and you're on a boat, you know, or if you are in a typh or you happen to be vacationing in a typhoon prone area. In anxiety, you could just be in a boat and it's raining and your anxiety is telling you that there is going to be a storm, no? So in anxiety, there is actually no evidence that the person should feel the fear, no? Because there is no announcement of a storm. Okay, so in what an anxiety becomes a disorder when it becomes chronic. No, it becomes frequent. It takes a long time to subside. It becomes more intense. You know? And again, it interferes with the way a person functions. So this is the criteria for a generalized anxiety disorder. So again, there's excessive anxiety and worry. You might ask, what's the difference between anxiety and worry? Worry tends to be in our mind. So we tend to think about to think to be thinking when we're worrying. For example, I worry that um, the people at the other end of this Zoom meeting might be sleeping already. Anxiety is more somatic or visceral. It is accompanied by things that you feel, like the sweating, you know, the cold and clammy skin, the tremors, the palpitations. Okay, and for it to be a disorder, it should be um, at least 6 months. You know, that that it occurs continuously, and that it is difficult to control. So what else? And also that it should be accompanied by at least three of the following symptoms: you know, being edgy or restless, you know, being easily fatigued or tired. Again, just like in mania, difficulty concentrating, also in bipolar disorder, you know, irritability, increased muscle aches and sores, and difficulty sleeping, you know, because of the worrying, you know, and the restlessness. On the other hand, a panic attack is a bit like anxiety, just more severe. No, so the key word would be a sense of impending doom. And a panic attack takes minutes to hours, and it A panic attack can occur to anyone, but it becomes a disorder when it is recurrent, with one or more attacks, followed by at least 1 month of fear of another panic attack. So what happens is, because during a panic attack, a person tends to have so many symptoms, just like in anxiety. So the difficulty of breathing, and all those somatic and autonomic symptoms, the person tends to fear having another panic attack. And in the course of worrying about having a panic attack, the person gets a panic attack. That is how it sometimes becomes a disorder. So, four or more of these should be noted. Um, Palpitations, sweating, trembling, shortness of breath, uh, feelings of choking, chest pain and discomfort, nausea, or any discomfort in the abdomen, feeling dizzy, light headed or faint, uh, chills or feeling heat, so they could be opposite, numbness, the feeling of unreality, which is what we call derealization, and being detached from oneself, and as mentioned earlier, a fear of impending doom. So that's fear of dying, a fear of losing control or going crazy. So people tend to go to an emergency room um, because of a panic attack. But any personnel who mans the ER should also consider, first and foremost, should rule out a medical condition when it comes to these. So because it could be a signal of an actual medical emergency, like a heart attack, you know, and or because there are palpitations, or a very high blood pressure, and or even a stroke. So the next category of mental illnesses would be substance use and other addictive disorders. The following are the list of um, of or the classes of substances that are commonly abused. So as you can see from that list, caffeine is actually a substance. That is because in the slide or slides that will follow, you will find that caffeine um, tends to produce the same effects uh, on uh, on the body's receptors, and tends to display the same characteristics as these other um, substances, like, for example, tolerance. You will find that just like alcohol and any illicit drugs, um, the more you increase your caffeine intake, the more your body will develop tolerance to it. No? So that those who abruptly stop drinking coffee will complain of similar withdrawal symptoms to say alcohol, um, or a stimulant drug. So that when you for a person, for example, who is used to drinking, let's say, 5 cups of coffee per day, and you make them stop the next day, they are going to be agitated, they're going to be irritable, they won't be able to sleep, they will sweat, and all that. So when it comes to withdrawal, so one of the things that these have in common will be withdrawal symptoms when you stop these substances. Okay, that just we just put that picture because it would be easier to memorize. No? So basically, that's part of the criteria. The slide after this would be the actual DSM-5 criteria. And so there's craving, um, finding it hard to stop using the substance, you know, even if it endangers your relationships and your life and your health. Okay, so this is the criteria for a substance use. So this will apply for any of uh, the substances that have been listed. So it could be alcohol, it could be methamphetamine, um, or coffee. No, although it doesn't seem to be as severe, with coffee or any of those substances. So what does it say here? Two or more of the following within 12 months. One tends to take larger and larger amounts of the substance, wanting to cut down but not being able to, spending spending effort, no, spending time and using or recovering from the use of a substance. So people who are addicted, for example, um, let me see if it's here. Okay, people who are addicted, for example, with here in the Philippines we call it shabu. It's with methamphetamine. No, their relatives, their family members would complain to the therapist that um, one day they would just lose an appliance and they wouldn't know where it went. So the person would actually do anything just to be able to acquire the substance. So they tend to steal from their family members. They tend to sell their appliances, and even tires from their cars, and basically anything, so that just so that they can exchange these um, for the substance. And so obviously there are cravings, and urges to use the substance. What else? You know, so sometimes when a person's functioning is severely infected, their work, you know, um, both at home and school are affected. They continue to use even if the substance use becomes a subject of contention. So they fight within the family because of that problem, and but the person is unable to stop. Sometimes their spouses would threaten to leave them because of their substance problems, but they are unable to stop. And sometimes they give up important um, social and occupational and recreational activities because of the substance. So some of them are not able to attend to their roles as fathers, as mothers, as um, or whatever role they have in the community because of substance use. So they use the substance again and again, even if they are put in danger health wise. And tolerance means here needing more of the substance to get the effect you want. So that it's like with coffee. Sometimes when you feel that you need to drink coffee because you have work to do until the middle of the night, and the next night you keep doing that, you will find that one cup is not going to be enough to keep you up the next night. You will have to drink two more cups until it increases and it increases. And as I have said, the last one is the development of withdrawal symptoms. So you will find this when you abruptly stop a substance. The following are mental disorders that are induced by substances. So that the the chemicals cause um, an an imbalance of neurotransmitters in the brain, and they produce these disorders. So it doesn't a person doesn't have to be bipolar or schizophrenic, inherently, but because of a substance, they may experience mood symptoms, depression, psychosis, and everything else that's listed here. So neurocognitive disorders, so the brain disorders. You will, I don't know how many of you have heard of delirium, but sometimes it gets confused with dementia. Delirium is acute. It A person who is delirious is confused, and may tend to have hallucinations, and have cognitive problems. In dementia, it is more. Dementia is actually a general term, an umbrella term, for loss of memory, uh, problems with language, being unable to retrieve, to memory what a certain word or a person is called, having problems with cognition, meaning problems with problem solving, with judgment, with concentration, with abstract thinking, with math, and they tend to affect again a person's functioning. So a delirium would be a disturbance in consciousness, meaning a person um, fluctuates from uh, being very conscious to being confused. No? So again, it is a change in cognition. Also, a person tends to be disoriented. So delirium is the kind of condition you would usually find in an emergency setting, or a medical ward where the diseases, the person's condition are severe, like severe infection, no severe blood loss. Anything that disrupts the normal chemistry of the brain would result to delirium, and it could mean a medical emergency. So in delirium, usually it just develops for a short period of time. As soon as you can address the underlying problem, the delirium would also be solved. So you can safely say that the behavioral changes um, result from is delirium when they logically result from um, an organic cause, like for example, based on your history and physical exam and lab findings, there is an actual medical cause, like as in an infection, or a substance, or maybe caused by another medication. While dementia, there are actually different kinds of dementia. As I have said, it's a medical term. So it's the difference lies with areas of the brain, and the actual anatomic and physiologic effects on the brain, no, and the cause as well. These are the common types of dementia. So Alzheimer's disease, is the most common type of dementia. Another type of dementia would be a vascular dementia, where it's usually more acute. It can occur after a stroke, you know, and so you can see them in persons with problems in their cardiovascular system. The difference between the two would be one is acute, one is gradual. Um, Dementia is more fixed. In other words, you can see that a person who is starting to have dementia, you can see the constancy of the changes in their behavioral patterns. But in delirium, usually when you solve the problem, you also solve the delirium. So dementia, by the way, is um, a, a degenerative disorder. So medications, especially in the early stage, can slow down dementia, but dementia will just progress. You can't reverse. Schizophrenia and other psychotic disorders. May I know how much time? How much time? I'm wondering how much time I have. Um, so schizophrenia. Under schizophrenia, these are the other psychotic disorders. I don't know if you've heard some of them. There's brief psychotic disorder, delusional disorder, and so for this lecture, I will only be discussing schizophrenia, which is more common. The difference between a brief psychosis and a schizophreniform disorder would be the time frame. So the same symptoms as schizophrenia, but a brief psychotic disorder would just last from 1 day to less than 1 month, and a schizophreniform disorder would be from 1 month to 6 months, but 6 months and beyond that would be schizophrenia. So the thing that distinguishes these all of these disorders would be the presence of psychosis. So by definition, psychosis is a loss of reality, no? And so there would be a presence of either delusions or hallucinations. And so as for criteria, you have to have two more of either a delusion or hallucination. No, and then it can either be a disorganized speech, no, or disorganized behavior and negative symptoms. A hallucination um, is when a person hears or feels, no, or sees things when there is no actual stimulus. In other words, there is no actual thing that's producing a sound. there is there's basically nothing there, but the person's hears, or sees things. There could also be tactile hallucinations, especially in withdrawal symptoms, where people tend to feel that there are bugs crawling down their skin. A delusion, on the other hand, is a fixed belief. In other words, it's not something you can argue with a psychotic patient. If a patient believes that somebody is going to kill him, you can't argue with that. Or if a patient believes that um, um, he or she is being watched and spied on by the FBI, it would be difficult for you to argue with that, no? Because delusion is a fixed, false belief. No, so you might also find persons with disorganized speech. No, so speech that you can't understand sometimes. No, there could be different kinds of those. Grossly disorganized behavior would be like, for example, a person throwing around, throwing his feces, or just urinating anywhere, or like the persons that you see walking in the streets and just gathering um, anything, trash. Negative symptoms are the opposite of the above. So a person tends to be blunted. They have no, you can't see any affect in them. They, it seems that they have no feelings. And oh, the heading is I am sorry, it's not psychotic disorders. These are the developmental disorders, and I would like to apologize. I will no longer be discussing the um, developmental disorders, even though um, I know that they might be interesting to some of you also, because in the interest of time, and also I would prefer that a child psychiatrist would discuss developmental disorders. So under developmental disorders would be ADHD, autism, um, intellectual disability, which we used to call mental retardation. So under these are also the learning disorders. No? So these are very separate disorders that have really that have separate DSM-5 criteria also. No, um, and it I think it would take a really long time to be discussing them. Okay, so when it comes to the causes of mental illness, no, all of those illnesses that I have mentioned actually have a few things in common when it comes to causes. No, the first is genetics. um, uh, y- researches, and especially twin studies, now you will find that um, a lot, a big chunk, of the cause of and any mental illness would actually, it's because that it runs in the family, and you will only see that when you do a family history. Um, but other factors, so a person doesn't just become um, psychotic um, for a single cause. No, it usually is um, a combination of all of these different factors that affect a person's mental health. No, so again, genetics is a very big factor, but what happens to our experiences in our lives since childhood and and until the present, they tend to um, to to have a to have an effect, little by little in our mental health, and how we are brought up, how we were taught to face life's difficulties has also an influence on our mental health. So, like for example, in this pandemic, we are all, I'm sure, experiencing the same things, and similar difficulties. But how we react to the difficulties that this pandemic has brought us, um, it would seem that um, we all react to it differently. We have very different coping styles and mechanisms, and it all has something to do with with genetics and and our psychological makeup, no, our personalities, and how we were brought up to face problems. And as for the management, so this it it's obviously it would be different for each psychiatric condition, but um, what a therapist would look um, into in managing any illness would be summarized in these four. No? So, it, would the one would ask, would the patient need medications? No? So when in terms of medications, they could be there's a lot, and sometimes we make in depression, for example, we may opt to give medications or not depending on the severity. Psychosis has to be medicated, no? Unless it's transient, like it's a psychotic symptom because and if it's a just part of delirium, no? So the decision to prescribe medications or not would come both from the suggestion of a therapist, and also with the agreement of the patient, and another um, important um, area in the management of any psychiatric illness would be psychotherapy. So there are times when patients may not have to take um, medications because conservative treatment with um, any psychotherapeutic um, treatment would possibly be helpful. Um, Psychosocial management of a patient would mean preparing a patient, for example, to be integrated back into society, um, which is why there are also halfway homes, teaching a patient new skills so that they can cope with their present illness, you know, um, collaborating with different areas of society, as in the church, their local community, the school, so that what is so that one can achieve the best and try to come back to the most optimum, functioning and life that the person has experienced. So a physician's plan could be categorized into short term. So short term could mean just managing the psychosis, and long term would be um, the psychotherapy and psychosocial management. Okay, so it is said that the church is a a hospital. Have you have you heard someone say that the church is not a museum for good people, nor is it a club for saints, but the church is a hospital? I don't know if there's anyone here who hasn't ever been in an emergency room, but in an ER, you know, like that one, it's manned by people who know or who are supposed to know what to do in different kinds of emergencies. So so that a mental illness could actually be one of those emergencies. So how do we become equipped um, to deal with persons with a mental illness? How should we, as members of the church, help people with mental illness? No, because we are told that we are actually mandated, to comfort those who are in trouble. That's in 2 Corinthians 1, 3, and 4. And so I believe that the ability to help someone with a mental illness will be greatly influenced by our own mental wellness. Um, so that it has to start with you, with me, with myself. I remember when I was applying as a first year trainee in psychiatry back in 2012. I was given a set of books for free because there was um, an applicant in the training that already started training, but somehow felt that she had to quit. And the reason for that is that um, every time she interviewed a trauma patient or a patient who is a victim of abuse, whether it's sexual abuse or physical abuse, um, she would cry, and even if the patient hasn't even started crying yet. So apparently she was finding it difficult to handle these cases. And so it seemed that the job wasn't for her. So, well, it doesn't necessarily mean that that you have to be stone cold in order to deal with this. No? And actually, we have to use the ability to feel for others so that we can be effective in managing them. But as our our mentors would keep telling us, the instrument has to be ready. In managing a mentally ill person, the only instrument that you have actually is yourself. You will be the gauge, so you have to be very objective, without losing your empathy. Um, no, you must be a clean slate. No, so you have to shed your biases. No, you have to understand that um, each story is different, and and um, and that it's not about you, it's about the person that you are helping. So you always have, I can remember when I was just the first year that I found it very easy. You will find it very easy, actually, any one of us, no, will find it very easy to be patient with a patient, no. But when I was the first year, I tended to be impatient when it comes to drug addicts. So that my supervisor had to, part of the training, it was that you had to be processed, so that you will discover you why you find it difficult to be therapeutic, to a drug addict. So you have to start with yourself before you can start helping other people, especially people with mental disorders. No, I couldn't quote that for myself because this guy already said that. Now, be the change that you want to be in the world. Now, start with yourself. Okay. So the values that I find that are also just as important but are also very self-explanatory would be compassion, of course, and patience. Now, these are mentally ill patients. So that sometimes they will shout at you. Sometimes they will overreact. Sometimes they will not say anything. So you need to be extra patient with these patients. And obviously empathy is very important, and also open-mindedness. And equally important is effective communication. So these are things that are helpful. No? When talking to a mentally ill patient, for example, we need to have a tone of voice that is calm and reassuring, and preferably not very high pitched, because usually high pitched, according to studies, high pitched voices um, tend to give people an impression of being um, a bit emotionally unstable, not psychiatrically unstable, but a person could be reactive. No, that's not from me. That's according to studies. So that you will find that people um, who are employed, for example, as the voices, no, in advertisements, the voices tend to be well modulated and low pitched. Okay, what else? So, in the Adventist Possibility Ministries, that's a this group ministers to persons with disabilities, which included mental health. No, these are they have identified 6 goals in ministering to populations with mental illness, which I believe any church could adapt, so that they can be equipped to to deal with persons with mental illnesses or disability. So first is accessibility, meaning that the church should be able to provide an environment in which everybody feels welcome. You know, um, and whether or not and regardless of having a mental condition, the person should be able to access, whatever the church has to offer. Sometimes accessibility may be as practical as giving assistance to persons who find it difficult to find transportation to go to church, for example. No? So accessibility, education is very important, because in this age of, what do they call that, infobesity, there's information overload. it would mean also that there tends to be um, a considerable amount of misinformation, you know, so that any educational outreach, to members of the church would be very practical. No, so I'm sure you've had, for example, you've already had the lectures from the lecturers that have come before me. I was told that you've had a lecture on dealing with the stigma of a mental illness. That's a very good lecture. I'm sure that probably a lot of you have already had trainings in psychological first aid. So for churches who have not had this, it would be a good thing to have for their members. First for possibly the small group leaders first, and then the interested members. And another a value or goal would be would be encouragement, and the goal there is to promote participation in the different areas uh, of the church, and different programs of the church, because it is important that people with mental illness will feel included, so they should be encouraged to participate. Another would be accommodation. The idea here is to be able to include them, accommodate them in spite of their condition, so that they can even be part, as long as they are behaving and able and is being treated. They can even be part of church committees. They can be part of the volunteer services. They can be part of the church program itself, and the ministries. Support um is another thing. What we want is to be able to give support according to needs, and these needs can be varied. They can be as practical as transportation. They can be or they can be in the form of an advice. And of course there is ministry or service. Ultimately, that's what we do as a church. We reach out, but not just reach out and take things for granted. No, we reach out with understanding, and let a person and an individual know that we believe in them, and offer them hope. So, what are some productive ways that you can respond? No, I'm about to end. um, okay, so these are more practical things. First of all is um, watch your response, meaning um, when somebody in church tells you that they have a mental illness, for example, please don't act shocked. By the way, the source that I have gotten this from is from Amy Simpson. She's an author, of a very good book, about mental illness and in connection with the mission of the church. And so that if someone, for example, tells you in church, that they have a mental illness, um, don't act shocked. Don't try to give them explanation why they are suffering. Don't try to solve the problem for them. Just accept the news as if you would accept a news of a medical illness. As if, for example, somebody is telling you that they have a back injury, or they have a heart condition. How would we usually react um, to these conditions? Normally we would show a loving and uh, compassionate demeanor. We have to be emotionally even, and not reactive. What else? The following might be controversial to some, but that is what Ms. Simpson is saying there. To consider helping financially. Why? Her explanation here is, well, it's nobody is being forced to help financially anyway, but you will find that there are those in church who are very willing to do that, especially when it touches, their hearts, and it tugs at their heartstrings, no, and you will find that a lot of mentally ill people tend to lose their jobs because of the disability, no, or because mental illnesses tend to be chronic, they become disabled for quite a time, and it takes time for them to get back to their normal lives, so that financial help would actually be something else. No, if you it or it doesn't have to be financial help. No, we can see to their other needs, no, and be and give maybe in terms of goods. What else? In dealing with persons with mental illnesses, we have to establish our personal boundaries because they might tend to cross these boundaries. For example, how willing would you be for a mentally ill person to call you at home when they need your help? Do you want to be called at home? Do you want to be visited by a mentally ill person? So there are boundaries, and when you set boundaries, especially when you establish a group for the mentally ill, you have to stick to them, and because rules are very important for the stability itself of the mentally ill person. What else? If you include them in your group, you have to decide the kinds of behavior that you will tolerate. For example, you can decide that inappropriate behavior will have to be addressed, but make sure that you are addressing or giving consequences for the behavior, but um, being considerate with the mental illness itself. And then again, get training. It gives us the confidence to deal with these patients when we have actually gained some form of training, or um, uh, even just attending lectures. And another obvious way to be productive in terms of medical illness is to pray together, and to pray plus. Pray plus actually means that sometimes people tend to be uncomfortable when dealing with people with mentally ill persons. So they will just say, "Don't worry, I will pray for you." No, actually, pray for the person and do something for the person as well. Now, sometimes we tend to shy away from them because we are uncomfortable and we don't know what to do. You will find that it's actually, well, sometimes it is difficult, but you will find that these people can be just as open as anyone else. And there are times when their behavior becomes difficult to manage. They can become a danger to themselves with suicidal behavior, or they can become a danger to others by being violent. So there will be times when you have to call police. No, here in the Philippines, they sometimes call the barangay tanod, or the barangay, the officers of the village. So don't try to handle a violent um, mentally ill person by yourself. And obviously, for obvious reasons, refer to a professional when it is appropriate. So we have to remember that um, we are to be examples of God's love. Because sometimes how you treat a mentally ill person will be translated in their minds as to how God perceives them. So if we are rude to them, it could be they could get the idea that that is how God reacts to them. So it is important to treat them with compassion. So what would be the role of the church here, of the local church? So only two things are suggested, but there are a lot, of course. So This is from Dr. Carlos Fayardo of the Loma Linda University Behavioral Health Institute. No? He says here that um, it would mean development of networks of care that include the local church community and the leaders, along with the academic and public health um, sector. So everybody should be working together. So whatever referrals are needed um, should be done, no? Which is the second role. Um, so here, providing education, again, early identification of mental illnesses and the needed referrals. So they could be in the form of education, could be in the form of seminars, on depression, on trauma, on um, teaching coping strategies, so all of these things, that could be all of these services that could be offered en- to enable people, to deal with mental illness, no? And also to empower those who are interested in helping people with mental illness, so that to close, we are again um, not just encouraged, but I would like to say mandated now, because we are extensions of God, of His arms, you know. We are the extensions of God's touch, so we are to bind up the brokenhearted and to proclaim freedom for the captives and release from darkness for the prisoners. And we are to comfort all who mourn and provide for those who grieve. So I hope that you have learned a bit from this lecture. Thank you very much.
Thank you very much, Dr. Janice. So this topic is very broad, but we would like to thank you for giving us the important points, for giving us the role of the church, and for the relevant topic that you have imparted to us this afternoon. So now we will be opening our Q&A portion. So to our Facebook viewers, you can also write your comments down in the comment section, and we will be reading it. Or if you would like, you can unmute and you can ask a question or a clarification regarding the lecture. So I think we have two questions here. The first question is coming from Mom Cindy Kwan. So this is the first question, Doc. What do you mean by impaired interpersonal social occupational functioning?
So when it comes to impaired, in other words, functioning um, is affected. In other words, for example, their relationships, because of the behavioral changes. They tend to become misunderstood, especially when the people around them know, whether they're their co-workers, their classmates, or their bosses, and even their family members, even their girlfriends and boyfriend might not understand that they have an actual mental illness, and so they behave differently from the usual. So that is an impaired interpersonal relationship. So they could get into fights. People, for example, with personality disorders, and or people who are experiencing mania in the workplace, they become irritable, they shout, they become angry, and they tend to shout at other people, and co-workers. So in the process, their relationships are affected. No, so social functioning would be because of the mental illness, and their difficulty to organize their thoughts, they might not do their usual functions in the community, like their role as a church member, their role in the local community, their role as a student or as a worker, and their role in the family.
So thank you very much, Doc, for answering. So Ma'am Cindy, did it answer your question?
Yes,
So,
yes.
okay. So you have a follow-up question here from Mom Cindy too. Can you tell us more about trauma and stress disorder and eating and feed disorder, recurrent thought of death? Does it always follow the order as you put in the slide? Okay. So she's asking
Um, no, so this could be very different and separate entities. No, for example, an eating disorder would an example would be bulimia and anorexia. No, so there is a separate diagnostic criteria for that. Um, the shortcut for that would be bulimia would be retching. No, they would eat a lot, and then because their self perception is impaired. No, they think that they are very fat even if they are very thin already, so they eat a lot because they can't help it. But then they would retch, induce themselves to vomit. Anorexia, they would just not eat at all because um, even if they see that their weight has been declining, what they see in the mirror, or that they are normal, what they see in the mirror is somebody who is very fat. No? So that what else were we asking about? A trauma? Was it trauma? So under trauma would be post-traumatic stress disorders. You know, for example, it's the kind of disorder that you would um, observe, so there are specific symptoms that you would observe from persons who have experienced anything that is traumatic, anything that could have endangered their lives, or they could have witnessed something that endangered another person's lives. No, so the term post PTSD or post traumatic stress disorder was first noted because of the war veterans. They noticed that the soldiers who came from war would suddenly, even if they are at home already, they tend to be very alert. They tend to wake up alert with very when they hear sounds. No, um, those who suffer from post-traumatic disorders would also be those who have, for example, experienced sexual abuse, no, or physical abuse. So, for example, I have a patient right now who is already in the hospital because she was very suicidal. Um, when it becomes dark, no, when late in the afternoon, no, when the sun comes down, she would have panic attacks. And then right now I haven't been able to talk to her, but I am assuming it is a possibility would be that her abuser, who is her uncle, usually would start abusing her at nighttime. That's why she, even if she is away from the perpetrator, she still experiences symptoms that she would experience during the abuse. So that is called a post traumatic stress disorder.
Okay, so
What
thank you, Doc. Yes po. Do we have any more questions?
Good afternoon, madam. Can I ask question?
good
Yes, sir.
afternoon.
Go ahead. Go ahead.
Yes, good afternoon, Janice. Salo here. What is the what is the chance of recovery? How many percentage? Halimbawa, once diagnosed with nervous breakdown, percentage of recovery.
when it comes to thank you for that question, Pastor Salo. When it comes to percentage or chances of recovery, it is very important to diagnose exactly. For example, it a normal person, a regular person might experience depression because maybe she lost a loved one, and then at the same time she failed a board exam or something happened, no. So a person, it is possible for a person to experience a major depressive episode just once and then recover from it forever. No, but once you diagnose a person, for example, with schizophrenia, that is the diagnosis of a lifetime. um, you don't There is no cure for schizophrenia. The purpose of medications is to control the symptoms so that they don't become violent, they don't kill themselves and other people, no. So but because it's genetic, it's like hypertension and diabetes and asthma, no. A lot Most of these mental illnesses are genetic, no, so that you can't really cure them, but you can control their symptoms. But the ones that people can recover from are post-traumatic stress disorder, because it's just because of the experience. So if they are processed very well, then they get a good therapy and they have a very supportive support group like their church and their family members. um, they tend to recover and be well again.
Does it mean, Jan, that the most significant factor among is the genetics or the mental disorder?
Yes, yes, it is because um, you can't get away from genetics. No? When you take a family history, for example, especially in bipolar disorders, no, and schizophrenia, you will find that there is always going to be a relative with behavioral changes. And if you read the recent researches, you will also find that there are chromosomes that they identify with alcoholism, for example.
Thank you.
Okay,
I
thank
want to
you.
ask a question.
Yes, yes.
Uh, Regarding this recurrent thought of death, right, is that but with no suicidal preparation, is it considered as a depression?
Thoughts of suicide are a symptom of depression. So and yes, in the just because a person has recurrent thoughts of death, it is most likely that the person has it is likely that the person has depression, but it can also be part of schizophrenia. For example, there are patients who are told by the voices um, that they hear that they should commit suicide. So um, so that's it. So in other words, um, a suicidal thought does not necessarily equate to depression. You need to find out why the thought is there. No? Or for example, a person with borderline personality disorder, their dysfunction comes from their fear of being left alone, so that and and they tend to have very unstable relationships, so that every new relationship that they have, and if another new boyfriend will threaten to leave them, they will threaten to kill themselves. So that might sound like a recurrent thought of death, but it actually has something to do with that person's condition.
Can I ask a question?
Yes,
Yes.
sir, Edward.
Yes. Thank you, Dr. Janice, for the presentation. I'm glad that we can get the PowerPoint files later. You know, in an educational institution, when we have when we have a student exhibiting such symptoms as depression or psycho what is it? Anyway, if they exhibit those symptoms and we we get treatment to to diagnose them, that's going to cost a lot. And if that person does not have health insurance, should a school actually maintain such students, or can we encourage them to just go home?
It actually depends on the policy of the school. No? So,
Mm-hmm.
um, if as a therapist, no, it also depends on the current condition of the patient. If a patient is severely depressed, for example, and tends to be very suicidal, um, we advise them to be admitted actually
Uh-huh.
until such time that um, they are managed, no, and they return to their previous functioning, no?
Mm-hmm.
And but if it is a milder form of depression, then maybe a regular trip to a therapist would suffice. No, so it depends on the school's policy. No,
Mm-hmm.
no, if for example the patient, the especially with teenagers, no, if he or she keeps displaying suicidal behaviors to her classmates and she influences them, no, so it can be now a the prerogative, no, of the school to either let the patient rest for a while until she has a clearance from her psychiatrist, no, or something like that.
Okay, ma'am, I have a
Thank you.
question. Hello.
Yes, ma'am.
Yeah. Is there a cure for the bipolar? Because I have some friends who has that kind of medical condition. Some opted for the medicines and some for injections. Is there a cure for them not to repeat the episode of that one?
Bipolar disorder is also like schizophrenia, ma'am. It's genetic. No, so usually a doctor would not immediately diagnose until the doctor is sure. No, because it would mean a lifetime of treatment. No,
Oh,
so you will find that so one of the things that the one of the causes of a relapse is
ah,
when the symptoms come back, no? It's because patients who were under medication, obviously they become well again, they become functional again, and then they will start thinking, then maybe I don't need the medication anymore. So they will start skipping their meds little by little until the chemical imbalance, because it's the chemical imbalance in the brain, starts coming back little by little also until it becomes a full-blown manic episode again. So
so
it's a cycle.
yeah. So it means, mom, if one, for example, that one of the grandparent has the sickness of that one, it will be inherited by the grandchildren, one of the grandchildren.
There is
Possibility.
there is only a percentage, no, and it depends on how on if there's only one parent or both parents. For example, um there is a 12% probability in schizophrenia, and I think also in bipolar, that that your one of your children will have it if both parents have it. So that's 12%, but you could be part of the 12%. So it doesn't mean that um, um, the following generation will express it. It could be possible that it could skip a generation, but they still carry the genes. Yes.
Mom, another question.
Um,
If yeah, if the
uh,
girlfriend and the boyfriend are both bipolar, they should never get married. Just have that relationship going on. That's all. No more marriage. Because I guess if married, automatic the children will inherit. What can you say about that? Even if they are so in love with each other, because I knew someone like that. The relationship goes on, but both were really bipolar. There are
Oh,
times when, yeah, because the
okay.
guy was a
Ma'am,
foreigner
okay.
and
I'm
the
sorry,
lady,
ma'am, to cut you short, but I
yeah.
think Doc Janice has a duty to attend to.
Okay.
So, but
I
maybe she can answer
the
the
last
question the last time.
um yeah, in actually in reality,
Mm.
um if you ask me, if I have established a very good relationship with my patient, I will start making her understand um her illness, and that it is ultimately going to be a bad idea,
Uh-oh.
that she should be um but I would not put it that way, of course. No, I would eventually, ultimately it's going to be their choice. No, but you have to present to them the possibility that is a very high likelihood of having offsprings with bipolar disorder.
But mom, if they are both, for example, the lady is already 52 and the foreign guy was already 57, so there's no possibility to have kids. Just the two of them. But
Yes.
but the problem, if both bipolar, both ends, if one had the what is that, relapse, what will happen to the other one?
Sometimes it depends also what you encourage your patient and what you discourage them to do. Sometimes depends also on their level of insight, so that there are patients who have very poor insight, who tend to skip their medications. Now, these are the ones we want to discourage from being partnered with another person with a mental illness. But the ones who have very good insight, the ones who understand how important the medications are, and the ones who understand that they have to adhere to these medications, sometimes you can trust them to make sensible decisions, so that even if one partner has a psychotic or a manic episode, you can you if the other partner has a very good insight and very compliant, and they tend to come back to you often, then then they survive.
Okay. Because I have to advise some of my friends. That's their problem. That's why um, I don't know if what will happen to the relationship. I just like to help them.
I'd like to ask one question, doctor. For this mental psychological health problem, right? Like you mentioned, there's no medicine. Yeah, this different from the traumatic, which you can give them help. So you also says that all we can do like give support and empathy, and then we also must build boundary. Yeah. So I want to ask about. So how about those like with spiritual those that affected by spiritualism? Does it affect the childhood development, and then also cause this affect the normal child development like personality? Is it considered as can we help them just consider a traumatic case like that?
Those changes in behavior that are due to spiritism um, tend to be a unique case. So you have to be, as a Christian, for example, as a Christian doctor and psychiatrist, I would know what it's like if it's real possession, for example, right? In my school, in Mountain View College, I've seen that, levitation and all that. But a lot of patients, for example, come to us who are just schizophrenic, no? So they have hallucinations and delusions, and they say that they have been possessed, or their family members tell us, and this person has been possessed because the devil talks to him and all that, no? And she changes her voice and all that. But the thing that's funny is, um, the possession goes away with the medication, so that you know that it's actually just a symptom of the mental illness. I believe that as a Christian, when it's real, when it's real spiritism, when it's real possession, you would know it. No, it it's I think it's you don't need to be a specialist for you to know it. No, and in any case, whether it's spiritism or a psychiatric illness, we all need spiritual support anyway. No? So it would be all the same story. No, no, I can't say right now because it's been a long time since I've seen an uh that event, no, a possession or a spiritism. But all the cases that I have seen so far in the hospital that claimed to be has to have something to do with spiritism, they all got well with an antipsychotic medication. So I'm not saying that that when um because I also believe that elements of of our enemy, no, or Satan, are at work anywhere. You know. All I'm saying is that everything that I have seen so far in the hospital has all been psychiatric. You know. So I still don't discredit that because I believe in what the Bible says. I believe in the experiences of all those characters in the Bible that experience real demon possession and spiritism.
Okay, so thank you very much, Doc Janice. Thank you for sharing to us your expertise, and thank you also for the questions. And before you go, I would like to give this token of gratitude, the certificate of appreciation, in grateful recognition and appreciation for Dr. Janice Taleon for imparting her valuable insights to the participants of the We Care for Your Mental Health webinar organized by the SSD Health Ministries Department, given this 15th day of October in the year of our Lord 2020. Signed by our President, Pastor Samuel Saw, Executive Secretary, Sir Rudy Baloyo, Treasurer, Sir Max Langi, and our very own Health Ministries Director, Dr. Maria Rizalin Alfanoso. So, Doc, this will be sent to you through email, and hoping that we can have you again for our next mental health series. Thank you very much, Doc, for your
Thank you
time.
very much also for your participation and attention.
Okay, so now we will move to another session, or rather another part. You will have the brain power workshop series. So I know that you are excited to go into your breakout rooms that will be assigned to you by our host. So a notification will pop out. So you just have to click the join breakout room, and then we also have our facilitators ready here. We have Ma'am Diane Guevara for the breakout room 1, Sir Jackson for breakout room 2, Sir Mark for the breakout room 3, Ma'am Gladens for 5, and myself in the breakout room 4, Ma'am Arian Alvarez breakout room 6, Sir AJ and Ma'am Christine Barona in the breakout room 7. So and please wait for a notification to pop out, and please click the join breakout room. And for our Facebook friends, I'm sorry, but we cannot we will be stop sharing the
Hello, Kish. Okay. I think I think her internet is unstable, so I guess we have to move and go to our breakout rooms. Okay, kindly accept the notification, and you will be directed right away to the breakout rooms. Thank you.